let's talk about D-MAPP. It's not the most easy to remember acronym, but it's basically about distal upper arm problems, and it's about doing something that will be digital and survive in the future. Next slide, please. So why do we want to do this, Grant? And next slide, please. So a lot of people on this call, or your friends or your family, will have a lot of pains from elbow down. That's where we're focusing, elbow down. And we're talking about all the things that give people hand pain. Now, a lot of this is tendonitis. That is, a muscle is just a lump of meat. At the end of each muscle, there's that long cord that attaches to bone, and muscles act as levers between joints. Where the muscles attach to bone, they become tendons and then insert into the bone. And a lot of pain we know now is related to tendonitis, or the cling wrap layer that surrounds tendons, called the tenosynovium. And if that's inflamed, it's called tenosynovitis. If you get a lot of tendonitis in your wrist, you get something called carpal tunnel syndrome, because your tendons are all at the wrist stuck under a thick band and they've got no room to expand. Now you know why the surgeons just put a cut through that band and give you space for your tendons to work, and that's why it works for carpal tunnel. Hand osteoarthritis is another problem, but I think it's always mixed with tendonitis. What was called repetitive strain injury when I was young, which is a real phenomenon, strong people doing too much or weak people doing just average amounts of stuff, load their tendons, load their joints, and they get lots of pain, and we still see heaps of that in our clinics. So whether you call it repetitive strain injury or tendonitis or whatever, it's all out there. So at one end, the muscles of your hand end at your fingers. At the other end, they end at your elbow. The inside and the outside, they attach. And if you've got pain where the tendons attach to the inside of your elbow, it's called golfer's elbow. And if you get it on the outside of your elbow, it's called tennis elbow. So these are common problems. This is also medically called lateral epicondylitis or medial epicondylitis, but somehow golfers or tennis elbow is easier for people to remember. So lots of problems in the arm below the shoulder that there's not very good evidence on what to do. So it's not a good area with lots and lots of healthy trials that tell us this is the best therapy, this is the bad therapy. When you go to doctors and they offer you very little, it's because they don't know what to do. And it's mostly because often there's not an evidence base on what to do, and it ends up being an experience decision. Well, I had 14 patients and I've given a few of them this and they did all right. That's the experience expert opinion on how things go. So we want to try and look at what can we do that's well evidence-based. These problems make up large numbers of people. Everybody here knows about pain. Everybody here knows about the complications of pain, the impact on sleep, on mood, on life, on valued activities. Is to me a good phrase of the things that arthritis and joint pain interfere with. And of course, there's the burden for the healthcare and for an NHS that's going to head broke because of all our common problems, such as musculoskeletal, diabetes, cardiovascular stuff. So we're just part of a bigger picture. Next slide, please. So we got together with a whole lot of other people around the country. No grant these days is ever one person. It's a group of people with lots of different skills who come together. And you'll be aware that for years now, patients were always part of those teams and have been and will evolve. And perhaps, Amy, that's a different topic that will get different and evolve over time. It's different now to where it was 20 years ago. and it will get more involved, and patients will get more involved at multiple levels in research in the years to come in the UK. So D-MAPP, a whole lot of people. We've got good physiotherapists from Keele. We've got great hand therapists from the University of Southampton. All around the country, we've pulled together people who care about this issue. The people in Aberdeen had done work already on distal upper limb pain and looking at the epidemiology. That is, where are the numbers? Where are the problems? What's the evidence base? So this is a group effort, and that's how this team will go. And that's how modern grants are. They're big monsters. But why make it digital? Because we've seen the direction of travel. You've seen the direction of travel that's been accelerated by COVID in a way that nobody expected, to have things go online. It ain't perfect, but it's here to stay. So we want a program that's going to be useful, and we want a program that if you can't get it digitally, you will be able to get it other ways. Why do I talk about a program? Because I could teach you an exercise right now, one exercise. Would you do it? Would anybody do it? Would I teach the same exercise for all these problems? There's a whole lot of things we don't know. And we know that one of the problems, and I say exercise first up because I do, as you sadly had to hear me say before, I think muscle strengthening is the route to salvation for most people. But we want to get people doing more than just an exercise. We want them to know their problem, know the future, do their exercise, and bring in behavior change techniques, bring in self-management processes, the things that are going to make these chronic problems, make our interventions for these chronic problems useful. So that's now why we have teams and a multi-component intervention. It's not do these exercises 10 times a day and here's an information sheet, which I'm afraid many of you out there will know already. That's often what happens. So we've got to change that mold, make for a well evidence-based intervention, and that takes a team, and it takes some years, and this is going to take us some years to do. So you are at the start of our journey. In fact, journey probably started when we first started pulling the grant together 2 years ago. Now we're just to the starting point, but lots to come.
This is to give you an overview of our plans, basically. So our research recognises that the only way to create something that really works for people who are living with these conditions is for them to be involved the whole way through, and for us to be guided by their experiences and their needs. So this idea of working together with and being guided by the experts in this area is at the very heart of D-MAPP. And for us, our experts are the people who are living with these conditions day to day, as well as the wide range of health professionals who support these people in managing their conditions. So across these 4 phases or work packages, we'll be guided by these lived experiences from the very early planning stages right through to designing the D-MAPP, going on to test it out, and finally the consideration as to whether the D-MAPP will work in the real life setting. So this slide is just to give you an idea of what our project looks like overall, and I'll go into a little bit more detail about each of these work packages shortly. But I'd just first like to introduce you to a method which is very central to the work that we're doing. So the voices and experiences of our experts are crucial at all stages, but perhaps most crucial when it comes to designing the D-MAPP. And for this reason, we'll be using a particular type of research method known as Codesign. Codesign is essentially about designing with a group of people rather than for a group of people. And it can be a very specific set of steps, but also more generally, it can be thought of as an approach to research, and one that recognises the need for these experts to be active partners rather than just advisors in the design process. So we don't want to just ask our experts for input or advice. We actually want them to be very much a part of the process. And we want to work with them and for them to guide us in shaping the final D-MAPP. So through co-design, researchers create opportunities to bring together groups with lived experiences, and using creative processes, sparking discussions and ideas in order for these groups to collectively come to a shared agreement or a shared solution. So we'll be using a particular type of co-design known as experience-based co-design. And this really emphasizes the value of lived experience. And it has its roots in the healthcare setting. So it's often used to bring together patients, carers, and health professionals with experiences of a particular service. And they come together to share those experiences, to think about ways that changes could be needed and also improvements, and coming to a decision as to what those improvements should be together. So we'll be applying these principles. So from our earlier planning stages, we'll have gathered some experiences, both of living with and managing these distal upper limb conditions. And we'll use these to create what are called trigger films. So these are essentially videos which share these experiences and are shown to these groups in order to spark shared discussions and ideas. And through these, we'll start to have ideas as to what the D-MAPP should look like. And together, we'll start to create prototypes, so very early ideas of what the D-MAPP could look like. And over a series of sessions, we'll work together to review and refine these until we come to a collective decision as to the final design for the D-MAPP. So I'll now just briefly take you through each of our work packages in turn, just to highlight how lived experiences are really weaved into each of the stages, building up to the co-design and then beyond. So starting with work package 1, this is all about gathering the evidence. So finding out what we know and what we don't know, and reaching an agreement amongst our key experts as to what should be included in the D-MAPP. So we first of all look to the studies that we have available and to the recommendations that are available. And as Professor Conahan mentioned, we're fairly limited in that area. So it's really helped us to identify a number of potential elements of support which could feature in the D-MAPP, but it's also shown us where there are gaps in the evidence. And for this reason, we'll be looking to our experts to help us build on and make sense of the evidence that's available. So we'll be asking them to complete a series of surveys, and these are known as Delphi surveys. And this is, as I say, to help us decide what should be included in the D-MAPP. So in these surveys, we'll be asking our experts to rate the importance of particular elements of support, whether that's particular exercises, information, advice, guidance relating to the use of particular splints. And also, they'll be guiding us as to how these particular elements could be delivered using the D-MAPP. And by completing these surveys multiple times, our experts will have the chance to review their decisions and to look at how others have rated the various elements of support, eventually coming to a collective decision about what should be included in the D-MAPP. Alongside this, we'll also be conducting some focus groups, so small group discussions, which bring together people from different backgrounds with different experiences of different distal upper limb conditions, and exploring their experiences of care, as well as their experiences of using websites to support their condition, and gathering their thoughts on potential features. Alongside this, we'll also be conducting interviews with a wide range of health professionals, so from physiotherapists, occupational therapists, to doctors and surgeons. And we'll be exploring their experiences of supporting the management of these conditions, and also getting their ideas as to the things that may support or pose challenges to the use of D-MAPP amongst their patients. So then, guided by everything that we've learned in work package 1, we'll move into work package 2, which is where this process of experience-based co-design comes in. So we'll bring together people who are living with these conditions, a range of health professionals, and ourselves as the researchers. And together we'll go through the process of experience-based co-design across a series of 4 workshops. And once we've collectively decided what the D-MAPP should look like, we'll start to explore how these different component parts may interact together. And we'll also begin to explore whether what we've created is usable and acceptable for the people who will be using the D-MAPP. Moving into work package 3, our focus will be on determining does it work? So for people living with these conditions, does what we have created improve their pain and their ability to function in their daily activities? And we'll do this within a clinical study or trial, assessing whether under very specific or controlled conditions, the D-MAPP works when compared to usual care. And by that we mean what is already available, whether that's advice from the GP or a series of physiotherapy sessions. And we'll be using lots of different measures to assess this, some of which will be what we call patient-reported outcome measures. And that means that we'll be assessing how effective the D-MAPP is from the patient's perspective. So asking them, how has it affected their level of pain? How has it affected their quality of life? And then just finally, work package 4. This is really about making sure that we get it right. And so it's not just about, does the D-MAPP work in a clinical trial, but does it work beyond the project in the real life setting? And crucially, work package 4 will run right across the whole of the 6-year project. So very conscious that these sorts of considerations are so important, they can't just be tagged on to the end of our research. And our colleagues at Keele are experts in implementation research. And this is research that looks at how can the results of studies be applied to the real life setting to work in practice. And our colleagues at Keele really share our drive and commitment to collaborating with experts in this area in order to create co-produced research. And they do this by forming what are known as communities of practice. And these essentially a group of people who share a concern or a passion for a particular topic and want to come together to deepen their knowledge of that area and do so through interacting regularly. So for D-MAPP, our colleagues at Keele will be bringing together a community of musculoskeletal practice, and this will gather together experts with lived experience of these conditions, as well as health professionals, people with experience of implementing research in practice. And they're also really keen to hear from what we call seldom heard groups, so groups of people who aren't necessarily represented in research, whether that's due to barriers such as language, culture, their health condition. So we'll be sharing our results with the community of musculoskeletal practice, and across the whole project they'll be taking a closer look, working together to consider any barriers or challenges which may be faced when it comes to using the D-MAPP in the real life setting, thinking about how we might overcome these and how the D-MAPP can be effectively implemented in practice. So this has been a little bit of a whistle-stop tour, but I hope it's given you a bit of a flavour for the D-MAPP project and the methods we'll be using, but also a real sense of how much we value lived experiences and how our research is really looking to empower and to kind of share the voices of those for who the D-MAPP will be so important.
Yeah, hello everyone. So I'm Lucy, I'm the research fellow on the D-MAPP project. I'm going to talk to you today about kind of public and patient involvement that will be happening in this work. So in all of the work that Kathleen has described so far, so I'm sure it's something that's well understood by everyone in this group for all of your sort of involvement in research that you've been doing. But I guess we classically have this idea that there is participants in research, so that is that they are giving research data and they're sort of the subjects of the research. And obviously, as Kathleen's described, actually in D-MAPP, that relationship is going to be slightly different because we're taking a more of a co-design process where they will be much more involved in sort of actually shaping the intervention. So instead of us just coming up with this website to support people and then doing the trial, we're getting all of that involvement in actually shaping how that looks. But also on top of that, in everything that we do, we will have public and patient involvement where we will be working with patients and members of the public about actually getting advice and input about how we should be carrying out that research. So yeah, we've sort of got these two levels. So the way we'll be doing that is that we are going to have PPI advisory groups that are going to be set up both here at the University of Leeds, but also at the University of Keele. And that's because in those work packages that Kathleen shared, different universities are sort of leading on different sections, but there will be a crossover between those two PPI groups as well, which I think will be brilliant. And it's really important to us that throughout this project, we have patients who are inputting and guiding us on the design of those studies, you know, the specific details of how we should be carrying out our work, the analysis. So, you know, in a lot of this, it will be the kind of context of the findings that we get from that, and also dissemination. And I think particularly what's very important to us is that we don't just disseminate in some, you know, very boring academic article that is behind a paywall where you have to pay like 40-something pounds to access the paper, so no one else can see it. We really want to be working but to be able to talk about the research that we're doing in a way that's accessible for everybody, and, you know, putting that in the right places, doing that in the right format. So whether or not that's making videos with animations or doing sort of short leaflets, you know, I think working on how we can best disseminate all of that, all of the findings that we've gotten. So if you want to go to the next slide, Kathleen. So just to give you a little bit of a flavour of what we're doing. So far, we are still in the process at the moment within the University of Leeds of setting up our PPI Advisory Group. But some of the parts of the project were kind of getting started very quickly, and we really didn't want that to mean that we weren't getting the PPI input into that work. So we had run a workshop and also just a bit of follow-up work sort of outside of them around a Delphi survey that we will be conducting, which is really in that kind of getting the original evidence. And so Kathleen and I worked away, and we developed what we thought were good instructions for using on how to complete the survey, and kind of and a good explanation of why we were doing this. And we, along with some other points, we took that to the group, and we had loads of fantastic feedback. So just to give you an idea, so this is about whether or not our explanation of why we were doing the survey was suitable to participants. And so you can see this is the type of feedback we got. So it was things like simplifying our language, using diagrams to clarify. I think what was really came across was this inclusive language. So using, you know, that it's we are asking you to take part in this research, that it's more inclusive, but also really important ideas around accessibility in terms of the background colour of the presentations, but also some of the colours that Kathleen and I had been using for our font. And so to kind of give the feedback to that group, we used a you said, we did format. So Kathleen, if you go to the next slide. So then based on that, here's the we did. So this is what it sort of looked like after we'd taken into account that feedback and then made those changes. And then we took that and then sent it back to those patients that have been involved and members of the public in giving us that initial feedback, and said, like, have we got it right? Have we covered everything, all of the points that you've made? You know, do you think we've met all of that criteria that you've set out? And actually there were a few areas where we still had a few questions. So based on the feedback, we were like, oh, we think this could be good, or maybe this option. And it was really fantastic to be able to sort of go back and check if we'd sort of made those improvements, but then also to have some areas where we could have a bit of further feedback. And I think it's made a huge difference. And we will be working hopefully with that same group a little bit more on the Delphi survey. And I just think it's so important that we get it right, what we sort of send out to our participants in the study. You know, I think taking that time to ensure that it's sort of easy to understand, that it's accessible, and that we explain as well why it's relevant to the people that we're asking to take part. So Kathleen, if you want to go on to the next slide. Yeah, brilliant. So as Amy said, underserved communities is something that we are really thinking about, the kind of inclusion within the D-MAPP project. And so I've taken this image from the NIHR. They have a project called Include, which is all about working with underserved groups. And this is just to give you an idea of what we might mean when we say underserved groups. And so there are things that you might expect, so the kind of demographic component, so that might be ethnicity and age, but then there are kind of other aspects, so occupation, someone's location. So I guess we talk, you know, a lot in about postcode lotteries. But what we're really encouraged to do is to think about who is underserved in the context of our research, because it's going to be highly specific. So, you know, from, as you can imagine, from study to study, who underserved groups might be would look very different. And so in the D-MAPP project, we think one of the areas that's going to be particularly important will be around digital inclusion and access to digital technologies. So as we've said, the plan is that D-MAPP will be digital, probably a website or an app. And so for those people who are maybe less confident using the internet, or wouldn't necessarily have the internet as a go-to place that they would look for healthcare, how can we make it as accessible as possible for those groups? I think another area will be around ethnicity. So we know that for musculoskeletal conditions more generally, kind of minority ethnic groups do seem to experience more of the burden. And I think part of the work is to kind of unpack why that is. And so I'm very excited to say that we're very close to securing some funding, but if we don't, with a current funding bid, if that doesn't work, we will get the money to do this work from somewhere. That we're going to be doing a piece of research that will be working alongside the D-MAPP project that's going to be specifically looking at the barriers and enablers for underserved communities, interacting with digital interventions for musculoskeletal conditions more generally, so not just the kind of distal upper limb conditions. And to do this, we're going to be using a different model than we normally do. So I kind of tend to think the way we tend to sort of design research studies and the way we ask people to participate is that we decide who we want to come, we put a call out to people, and we sort of ask them to come to us and to kind of take part in our setting. So that might be like, come to a focus group at the university or at Chapel Allerton Hospital, and so we can hear about your views. And I think when thinking about these underserved communities, we want to sort of flip that model on its head. And so Amy has been very involved in this, and I know it's been some previous work that's been done by the BRC that has looked at this. Well, what we want to do instead is we want to go out to local community groups, and we want to say to them, we can provide you funding to put together focus groups, and that you can invite people, you can work out how you want them to be run, and that obviously there's the questions that we want to ask and sort of what we want to get out of it, but instead of it sort of all being controlled by us centrally, we're empowering those local communities to run the sessions themselves. And then I think also in that way, I think hopefully it will be building those important relationships between underserved communities. And also hopefully, you know, with the kind of finance, the fact that we can give funding will also be giving, there's a sort of financial benefit for those communities. And I think it's really exciting to be sort of involved in this work. And I think it's also something that we know is going to be a long-term project, which is going to be about building relationships and building trust within these communities, and thinking about not only what we want to get from those interactions, i.e., you know, their input in the research, but also what can we be doing for those communities. So, for example, thinking about can we provide kind of simple advice around prevention of musculoskeletal conditions. And so, yeah, fingers crossed that will be sort of awarded that funding shortly, and that will be then colleagues from a number of different groups within the University of Leeds and the BRC who will be working on that.